My name is Anila Rao. I will be presenting a case of Barostim Baroreflex activation therapy, a novel approach to reducing premature ventricular contraction burden in a heart failure patient. We have no relevant financial relationships to disclose. Barostim is the first FDA-approved device-based therapy that utilizes the body's autonomic nervous system to influence neurohormonal activation and alters the natural pathogenicity and symptomatic progression of the course of advanced heart failure. It activates the baroreceptors in the carotid artery to stimulate the afferent pathways of the autonomic nervous system. The increase in parasympathetic tone and decrease in sympathetic drive result in the restoration of autonomic balance, which can improve cardiac structure and function, especially in heart failure patients. The autonomic nervous system is also known to play an important role in genesis, maintenance, and interruption of ventricular arrhythmia. Furthermore, parasympathetic dysfunction is noted to be associated with ventricular arrhythmia in heart failure patients. We present a novel finding of Barostim implantation resulting in reduction in premature ventricular complexes, or PVC, burden and ventricular tachycardia events. We present a 79-year-old male with a past medical history of atherosclerotic coronary artery disease with a history of coronary artery bypass grafts, ischemic cardiomyopathy with an ejection fraction of 25%, status post biventricular ICD implantation, and ventricular tachycardia. He was on guideline-directed medical therapy for his heart failure with reduced ejection fraction, which included aspirin, high-intensity statin, carvedilol, and sacubitril/valsartan. Due to the patient having 4 hospital readmissions for heart failure despite guideline-directed medical therapy and biventricular pacing over the course of a year, he was offered a Barostim implantation. Over the 4 months prior to implantation, he was noted to have an average PVC percentage of 8.2%, 5 episodes of non-sustained ventricular tachycardia, and 1 episode of sustained ventricular tachycardia. After the implantation of the Barostim device, he was noted over the 7 months post-implantation to have an average PVC percentage of 2% and no further episodes of non-sustained or sustained ventricular tachycardia. As you can see with the trend line, after Barostim implantation, the patient tended to have a lower PVC burden. He was found to actually have a 75.6% reduction of his PVC burden and no further hospital readmissions for his heart failure after implantation. After an extensive literature review, we found that there are no documented cases of Barostim leading to the reduction of premature ventricular contractions. It is postulated that Barostim implantation may lead to a decreased incidence of ventricular tachycardia. A possible mechanism for ventricular tachycardia reduction is a decrease in PVC burden. As seen in our patient, he had a 75.6% reduction of his PVC burden and no further hospital readmissions for heart failure exacerbation. The trend of reducing PVC burden and ventricular tachycardia events may be a significant driver for the significant results seen in the BHF trial, where they found an improvement in the 6-minute hall walk test and Minnesota Living with Heart Failure Questionnaire quality of life score, along with improvement of the NT-proBNP levels. Patients with congestive heart failure are prone to ventricular arrhythmias. Barostim baroreflex activation therapy is a novel approach to influence the neurohormonal activation and symptomatic progression in advanced heart failure. We present a novel case of Barostim implantation reducing PVC burden, non-sustained ventricular tachycardia, and sustained ventricular tachycardia events. Further investigation, however, into this relationship between the therapy's neurohormonal activation in relation to PVC burden and ventricular arrhythmia suppression is still needed. Thank you.